Hey there, and welcome to today's explainer. Look, if you're a focused learner trying to master the absolute essentials of anesthetic clinical guidelines, and you really don't want to dig through dense textbook pages to do it, you're exactly where you need to be. Today, we're taking a really close look at two critically important topics: the strict anesthetic requirements for intraoperative evoked potential monitoring and the incredibly high-stakes protocols for malignant hyperthermia. My goal today is to go through this point by point, skipping absolutely nothing. Every single detail from our source material is distilled right here, so you can lock these concepts in and never miss a beat when you're in the operating room.
Okay, let's dive into our clinical pathway for today. We're going to start with evoked potential monitoring. Then we'll define malignant hyperthermia. After that, we'll map out the clinical presentation timeline, walk through emergency treatment protocols, and finally wrap up with prevention and screening. Let's get right to it.
Part 1. Evoked Potential Monitoring. Let's briefly look at the strict baseline anesthetic requirements we need to get clear signals without interference.
So when you're inducing anesthesia, you really want to minimize pentothal. Why? Because it literally produces 30 solid minutes of suppression of evoked potentials, and we just can't have that. Overall, total intravenous anesthesia, or TIVA, is your absolute ideal setup. That means no inhalational agents at all. Now, if you are using propofol, don't worry too much. It only has a mild effect on EPs. In fact, total anesthesia with propofol causes less depression than inhalational agents at the exact same depth of anesthesia.
Now, what's really interesting about this is how strict the rules are if you can't use TIVA. A nitrous and narcotic technique is a very distant second choice. If you have to use inhalational agents, keep in mind that all volatile anesthetics produce dose-dependent reductions in SSEP peak amplitude, and they actually increase peak latency. Throwing nitrous oxide into the mix increases that sensitivity even more. So you absolutely must keep the dosage under 1 MAC. Ideally, you want it under 0.5 MAC, and definitely avoid older agents like halothane completely. But on a reassuring note, your non-depolarizing muscle relaxants, they have very little effect on evoked potentials.
We also can't overlook your sedatives and background meds. First off, benzodiazepines act as mild to moderate depressants on ESIPs, so definitely keep that in mind when you're dosing. Secondly, for delivery, a continuous infusion is always going to beat intermittent boluses. Boluses can cause sudden spikes and drops in your signal readings, so steady is always better. And finally, some good news. If your patient is on anti-seizure medications, specifically things like phenotone, carbamazepine, or phenobarbital, these do not affect SSEPs at all. That is great for your monitoring baseline.
So the crucial point here is that it's not just about the drugs. Physiologic stability is absolutely massive. SEPs can be significantly altered by hyperthermia, hypothermia, and any sudden changes in blood pressure. However, if you're purposefully hyperventilating the patient to reduce intracranial pressure, hypocapnia, even dropping the end-tidal CO2 all the way down to 21 causes only a minimal reduction in peak latencies. So you do have some breathing room there.
All right, moving on to part 2. What exactly is malignant hyperthermia? Let's take a look at the foundational definition.
By definition, malignant hyperthermia, or MH, is a hypermetabolic state of skeletal muscle. This happens because of an idiopathic block of calcium ion re-entry into the sarcoplasmic reticulum of the muscle cells. Basically, the muscle cells can't relax, so they just go into total metabolic overdrive. This condition is transmitted by a multifactorial genetic predisposition. The end result? The patient's total body oxygen consumption just skyrockets. We're talking 2 to 3 times its normal rate. Let's break down the incidence data, because these numbers really put things into perspective. It's actually more common in pediatrics, hitting about 1 in 15,000 anesthetic administrations compared to 1 in 40,000 for adults. The mortality rate is staggeringly high at 30%. But here is the most terrifying fact you need to take away from this. 50% of patients who experience an MH episode have actually had a previous, completely safe exposure to anesthesia without a single sign of malignant hyperthermia. No warning whatsoever. You can literally never assume a patient is in the clear just because they've had surgery before.
So what actually triggers this massive cascade? Well, it's frequently associated with halogenated inhalational agents and the use of a specific muscle relaxant, succinylcholine. In its most aggressive state, which we call the fulminant form, you'll see muscle rigidity almost immediately after giving succinylcholine. This really often hits the masseters, the jaw muscles, which leads to severe difficulty when you're trying to intubate. Oh, and keep your guard up, because an initial attack and even recrudence can still happen postoperatively. Part 3. The clinical presentation timeline.
In these situations, time is tissue, so let's see exactly what to look for and when.
Let's map out how this builds right from minute 0. The absolute earliest possible sign is an unexplained increase in end-tidal PCO2. Next comes the early stage, usually around 1 to 5 minutes in, characterized by tachycardia and other arrhythmias. If it's not stopped, it hits the progression phase over the next 10 to 30 minutes. This is where you see severe muscle rigidity and soaring fevers. Finally, it reaches the end stage, which is terminal, hypotension, profound bradycardia, and ultimately cardiac arrest.
We absolutely cannot skip the progressive horrors that happen in the middle of that timeline. As things get worse, the patient develops DIC, a severe coagulation disorder that literally causes bleeding right from the surgical wound and body orifices. If you draw ABGs, you're going to see rapidly increasing metabolic acidosis and a falling PO2. Pulmonary edema starts setting in, and the fever, it's horrifying. Elevated body temperature can reach 44 degrees Celsius, climbing at a terrifying rate of 1 degree Celsius every 5 minutes. And late in the game, rhabdomyolysis hits, heavily elevating CPK and myoglobin levels as the muscle just breaks down.
Part 4. Emergency treatment protocols. Let's urgently transition into the exact step-by-step actions required to save a life.
And this brilliantly illustrates your unhesitating emergency response. Step 1. Eliminate the agents. Immediately stop the operation, totally discontinue inhalation anesthesia, and physically change the tubing on the anesthesia machine so there's no residual gas. Step 2. Push dantrolene sodium. Start with an IV dose of 2.5 milligrams per kilogram, but you've got to be ready to infuse it up to 10 milligrams per kilogram until those symptoms actually subside. And step 3. Hyperventilate the patient with 100% oxygen. But you're definitely not done yet. You still have to manage the massive systemic fallout. First up, actively cool the patient. Use surface cooling or cavity routes like nasogastric or rectal. Then, hit them with targeted IV therapies. Give bicarbonate for the severe acidosis and administer IV insulin and glucose. The insulin is crucial to drive dangerously high potassium back into the cells, while the glucose acts as an energy substrate. Next, use prokinemide to manage those deadly arrhythmias. And lastly, force diuresis using volume loading and osmotic diuretics to flush out the kidneys and protect them from that rhabdomyolysis.
All right, part 5, prevention and screening. Let's slow things down a bit and talk about identifying at-risk patients before things ever go wrong.
Identifying these patients requires some really careful screening. The only genuinely reliable test out there is a 4-centimeter viable muscle biopsy for in vitro testing at a regional center. They essentially look for abnormal contracture when the muscle is exposed to caffeine or halothane. Clinically, though, watch for red flags. Any family history of the syndrome is a huge one. Also look for related traits. 50% of MH patients have heavy musculature, Duchenne-type muscular dystrophy, or scoliosis. And absolutely always note if a patient has a history of masseter spasm from prior succinylcholine use.
If you have identified a patient as at risk, your anesthetic choice has to be flawless. Here's the exact breakdown. Avoid succinylcholine at all costs. Just don't use it. Safe. You can safely use non-halogenated anesthetics. This list includes narcotics, barbiturates, benzodiazepines, droperidol, nitrous oxide, and non-depolarizing blockers. Actually, if muscle paralysis is essential for the surgery, non-depolarizing blockers are strongly preferred.
Finally, for those known at-risk patients, you can actually pre-treat them. Prophylactic oral dantrolene is usually highly effective. The exact dosage you need to lock in is 4 to 8 milligrams per kilogram per day, administered for 1 to 2 days prior to the surgery. But crucially, you must give that very last dose exactly 2 hours before the onset of anesthesia.
All right, we've covered a tremendous amount of ground today. From optimizing those evoked potentials by leaning on TIVA, all the way to shutting down a full-blown hypermetabolic crisis. But I really want to leave you with this final provocative thought. With a 30% mortality rate and a shockingly sudden onset, are you prepared to recognize the absolute earliest sign of malignant hyperthermia? That subtle, creeping increase in end-tidal CO2 before the clinical cascade becomes terminal? Stay vigilant out there, trust your monitors, and never ever underestimate the basics. Thanks so much for joining me on this explainer, and I hope this deep dive ensures you're completely prepared for whatever comes your way in the OR.